Great. So I'm just going to share the introduction slides. Perfect. So today's webinar is on the management of lung cancer during the COVID-19 pandemic. I speak on behalf of the How I Treat COVID-19 team. We are a group of medical professionals and mostly medical students who did a great job during the pandemic, trying to simplify information and make it available to the public. This initiative in terms of webinars is actually to be able to identify what are the issues that we figure are important to address between experts, patient support groups, and the general public. So today we have Dr. Paul Wheatley-Price, Associate Professor at the Department of Medicine at University of Alberta, and Mrs Anne Marie Cerato, who's going to be our patient survivor, and Boaz Wong, who's the coordinator and PhD candidate. And this event was done in collaboration with the Lung Cancer Canada and the Association Pulmonaire du Québec, and of course supported by the Quebec Cancer Coalition, who also provided us with an evaluation form that I will be able to email it to the attendees. It will be good to have your feedback, and not just like how are you living during the pandemic, so that we can be able to address these issues in the future webinars. So the outline is really very simple. Sorry, I didn't change this. It's a brief overview in the management of lung cancer. How did the pandemic influence lung cancer? And then a brief, and then a testimony from Anne-Marie of how the COVID was affect the follow-up of care. It's just small etiquette. It's click on the chat for questions. Sorry, the chat, you can see it in the screen. For any questions, just write your comments here. Use the gallery view to see the attendees. And for any other inquiry or follow-up, please do not hesitate to email us. And the format of today's session is going to be very simple. We decided together with Boaz and Paul to address all the questions for lung cancer. Is a very broad topic. And one of the major things that I believe are good to address is briefly, how was the management in the past? How did pandemic influence the management? We got sorted out many questions for Paul. So I'm just going to start at first. Boaz is going to take care also of the second question for the how has the pandemic, but I'm going to start at first with Paul. So I know that for lung cancer we had a huge advance in the management of lung cancer in the last couple of years, and mostly until now, especially in the last 3 years. So from diagnostic to staging methods, if we're going to talk about a journey of a patient regularly diagnosed, how would you describe a journey of a patient from diagnosis to treatment before March 10, let's say?
Well, good afternoon, good evening, everybody. And thanks, Ali and Boaz, for inviting me to take part in this. It's probably even worth thinking about the patient journey, really not at the point of diagnosis, but at what happens before diagnosis, because when we come on to talk about the impact of the pandemic, it may turn out that that's going to be the most important bit. So in general, and certainly until we have lung cancer screening in Canada, which we're pushing for, but currently the first thing is somebody gets a symptom. And common symptoms of lung cancer would be a cough that doesn't go away, a persistent cough, maybe coughing up some blood, getting out of breath. And one of those symptoms then generally would trigger the first interaction between that individual and the healthcare system. Maybe, probably most commonly, it's the family doctor. Maybe it's a trip to a walk-in clinic or the emergency department. And at that point, there's a question mark in that clinician's head. Could this be something more sinister? And so that's when tests start, an X-ray or a CT scan, which might then show a suspicion of lung cancer. Then there's a referral to a specialist center for a workup. And certainly in Ottawa, where Boaz and I are based, that we have what's called a diagnostic assessment pathway. So everybody comes into a central spot, but it might be different for you, Ellie, in Montreal, or for someone in Vancouver or Toronto or wherever you may be. I think we've got some friends from New Brunswick on the line. But initially, what needs to happen is there needs to be a biopsy to prove that this is lung cancer. And there needs to be a set of scans, maybe CT scans, PET scans, brain scans, to do what the process we call staging. So the biopsy to say, yes, this is lung cancer and what type of lung cancer it is, and the scans to establish the stage that it's at. And the type and the stage then define what the treatment options would be and who that individual should next be seeing. So if it's caught at an early stage, hopefully a trip to visit the thoracic surgeon for an operation to remove the lung cancer. If it's at a more advanced stage, then it's a trip to the cancer center to meet the oncologists, myself as a medical oncologist on the drug side of things, and our radiation oncology colleagues. So that's the broad outline of that initial path from first symptom to sitting down in front of the physician who is going to recommend a treatment plan.
So how about there's a major thing that was the advancement, actually the access to biomarkers. And there's still, I mean, even now, there's still a bit of discrepancy in how much time it would take to get your PD-L1, you get your EGFR, to get your ALK testing. Where do you do it? Do you get NGS? Where do you have it? So this is one of the major also advances that we had, but still there was a lot of challenges at this time.
Yeah. So exactly right. So maybe 10 years ago, pretty much the only drug treatment option we had would have been chemotherapy, or just maybe 12 years ago. Since then, there's been huge advances. It's advances in surgical techniques. There's advances in progression in radiotherapy techniques, but particularly in drug techniques. And it all comes down to this concept that lung cancer is not one disease, but it's a range of different diseases that we can now detect using, as you described, biomarker testing. And some of those tests identify specific subtypes that would have a specific treatment aligned to it, and those we generally call targeted therapies. They're generally tablet treatments. You can hear some firsthand experience of that from Anne Marie a little bit later. And then secondly, there's other biomarker tests, and you mentioned this one, PD-L1, which gives the physician a guide as to what treatment might be more effective if there's no target. And that's generally a choice between the newer treatments of immunotherapy, intravenous drugs that are very well tolerated for the vast majority of people, that get the body's own immune system to sort of activate up and fight the cancer. And we've seen some amazing results from immunotherapy. Now, biomarker testing then happens at the laboratory, and depending on where you are, it can take a varying amount of time. In Ottawa and in major academic centers, it will happen in-house. If you're in a more peripheral center, often it has to be sent out. That can lead to some additional weeks of waiting.
This is one of actually the waiting time is one of the major questions that we've been asked always. Why do things take so much time? And we always, sorry, as clinicians, we want to shorten the time from the symptom to the right treatment. And there's a lot of challenges. And why does it matter with COVID? Because with every step, there's a different contact with the healthcare system. And what we saw during COVID is that all our management and everything that we wanted to do is to shorten this time, but at the same time, shorten the access to different care and shorten what imaging we've been done. So how much time would you think is technically reasonable between diagnosis until treatment?
So if we're talking about drug treatment, then there's various time points that happen. So when the diagnosis is made, then there has to be a referral to the oncologist, and then that appointment. What we hope would happen is when that pathologist is seeing a diagnosis of lung cancer, that will trigger a referral to the cancer center. At the same time, that pathologist is not waiting for me to see someone in the cancer center and then go back to them and say, could you now please run those tests like the PD-L1 and the EGFR and the ALK and these various subtypes? What we hope is the pathologist is saying, oh, look, this is lung cancer, so let me start the testing in what we call a reflex manner. And so by the time Anne Marie comes to sit down in front of me for her first appointment, with all the stress and the anxiety that go with waiting with a diagnosis and not knowing what's happening, when she sits down with me, I can then say, well, look, you've got this is the stage, this is the type, this is the treatment, and then we can get going right away. Mm-hmm. So the challenge is, can we get that reflex testing up front in a very standardized manner for lung cancer patients across the country?
So one of the major things also is we split patients between curative intent and palliative intent. And most of the time, we try to do many adventures trying to mix different specialties, different treatments, chemo, radiation, surgery, immunotherapy, target therapy at the same time to try to bring the best outcome. So if we want to summarize the treatments into different categories, how can we make them simple? What are the different arms, or what are the things that we usually use for a specific patient?
Yeah, I think we can do that straightforwardly. So if you remember just a moment ago, I was saying that initially you come in and you have a biopsy, and then you have those series of scans, which is the staging. And broadly, there are 4 stages to lung cancer, 1 being the best, like an early, small tumor that's not spread anywhere. 2, they get a bit bigger. 3, they're generally in lymph nodes. And then stage 4, which unfortunately is the case for 50% of lung cancer patients at diagnosis. Stage 4 is when it's spread to other parts of the body and it's not curable. Roughly speaking, stage 1 and stage 2 and some stage 3, we want you to have an operation, take the cancer out, be done with it, maybe a course of chemotherapy or even a course of radiation afterwards as a sort of mopping up insurance plan exercise to reduce the risk of recurrence. Some stage 3s, probably most stage 3 lung cancer won't have an operation. It's too technically challenging to be confident that you can get it all out, or it would require too big an operation and somebody wouldn't have enough lung left. So in those situations, we use a combination of all of the other modalities that we have, which typically is radiotherapy, chemotherapy, and now also immunotherapy. And then stage 4, I haven't mentioned, which is the non-curable setting. Then the treatment, be it chemotherapy, immunotherapy, or targeted therapy, very much depends on all of that molecular testing and identifying exactly the correct subtype.
Oh, great. Okay, so I'm going to move now to just like with the major topic is how the pandemic has influenced lung cancer, and just in big titles, one of the things that we rushed to do is to try to find the balance between treating all the patients or exposing them to immunosuppression, or what will we do? So it was a crazy balance. So if we wanted to say like what are the benefits of the therapies and which treatments are done for each stage as we just described, how did you define medical emergency and what treatments were prioritized during this time?
Right, so that's the heart of the matter. So there's a very, in Greek mythology, Ellie, there's a story about a ship which is trying to get through the Straits of Messina, which is off the coast of Sicily, I believe. And it has to navigate between a sea monster, and a whirlpool called Scylla and Charybdis. And so there's this phrase stuck between Scylla and Charybdis, between a rock and a hard place, between the devil and the deep blue sea. And these are the challenges that we've faced with prioritizing. Do we expose somebody to multiple hospital visits and treatments, and could that put them at increased risk of COVID-19 infection or complications of COVID? Or well, if we protect them and keep them out of hospital, are they then at risk of the lung cancer causing problems because it's been untreated? So we have this challenge to navigate, and I think what we've learned in Canada is the same as we've seen around the world, that it's very different depending on where you are. So bits of Montreal have had different issues to other parts of Montreal. bits of Toronto likewise. Some of the rural areas in our country, many of the rural areas in our country have been relatively unaffected. The biggest worry I have is that that initial point when someone gets symptoms is they're not going to their family doctor. And so that we may not see those initial diagnoses happen. But to get really to the heart of your question, when people do get into the hospital with a suspected diagnosis or a diagnosis, there are various points where the pandemic might affect us. So the first question is, well, should we have capacity? Should you be coming in for treatments, or should you just be staying home? What's the biggest risk there? There's another group which is, okay, well, you do need treatment, for sure you need treatment, but should we adapt that treatment? Should we change it to a different modality, a different frequency, or even a different type? You have chemo instead of surgery, or vice versa, because that will reduce your risk. And the third scenario, which thankfully in Ottawa we've not had to deal with, is what on earth do we do if we don't have capacity? If our hospital system is under such strain that we can't physically deliver the services that we would want to. And in that scenario, where it's less making choices about altering treatments or choices about staying home, we're saying, okay, look, you can have treatment and you're going to have to wait. And thankfully, you know, those decisions we haven't really been forced into, but we have prepared for them. And they've been, I think, very carefully thought through, very thoughtful people, clinicians, patients, ethicists, to try and determine if we really do have to prioritize who would we really put first. And generally that's people who have got a high chance of success in treatment, people who are really imminently suffering or at risk, and people who can be cured as well. And it's thankfully we haven't had to say to anyone, you can't have treatment.
Well, one of the things that to add to that, one of the things that we saw in Montreal, so we saw prioritizing based on emergency, but emergency is relative. I mean, if you tell someone that you have a cancer, whether 2 centimeters or 7 centimeters, for them, every night that they're going to go to sleep, they're going to sleep with the back of their head knowing that they have a lung cancer. For us, a 2 centimeter can wait 1 month or 6 weeks to get surgery. So the emergency was really kind of defining this, was very relative, and it was stressful for everyone. That's why there was a huge way of how to prioritize. But one of the major things that we had in our hospital is the decrease in the number of patients presenting for the first symptom and being diagnosed. We had a decrease of 60% of patients diagnosed between March and April from 2017, 18, 19 compared to 2020, which was huge, because these 60% of patients, it's not that they didn't exist, they're just still at home. And this is now what we'll see. One of the things,
maybe I'll just jump in there. I think that would probably be our biggest concern. And there is now some good data starting to emerge about the impact of COVID on cancer patients. Early on, there was some very small amounts of data coming out of China, which suggested that cancer patients with a COVID infection did a lot worse, were at much higher risk of complications or dying of the coronavirus infection. But then if you delve deeper into that data, actually, we didn't really know much about their cancer, and some of them had cancer. They were cancer survivors from many years before. There's some very important information that's coming out of the UK, where they've had, I think last I heard, the second highest number of deaths in a country after the US. And they also saw a 75% reduction in the referrals over a time period in March, April. And they've modeled about what impact that might have in terms of more people dying of cancer because they're being diagnosed late. So this, I think, is the big issue. And while we're very cautious about, well, what if a lung cancer patient gets COVID? I think what we're seeing more is that the cancer diagnosis itself does put people at higher risk, but really cancer patients are at higher risk if they've got other medical problems too. And it seems to be if they're older, obese, high blood pressure, diabetes, those conditions alongside cancer really put people at higher risk. And there was some reassuring data just released about a week ago from the UK that people who were on active treatment for their cancer, be it chemotherapy, immunotherapy, targeted therapies, didn't seem to be at higher risk of complications if they actually contracted coronavirus, particularly when they accounted for those other factors like high blood pressure. So the infection itself and cancer, that's worrying, but it's the delayed diagnosis that I think we're cautious. We're a little bit more worried about.
Yeah, so the delayed diagnosis with upstaging of patients supposed to be stage 1 becoming stage 3 in September until they see again or they get their access to CT scan. One of the things that happened in Quebec, and I'm sure it didn't happen often in different other provinces or countries, is we had some little bit of loosening in access to specific therapies, change of indications, use of doubling doses. And one of the things also that was approached and was one of the ideas was to use immunotherapy as neoadjuvant. Now we have tons of trials undergoing. We have a few phase 1, one or two phase 2 that discussed immunotherapy with very high complete response rate, but we don't have comparative. We don't have access yet. But one of the regulatory organizations in Quebec suggested that if you have a very high risk disease and someone progressing and you're going to get to a point where your OR room is completely blocked, are you going to give immunotherapy before going there? So I don't know if you had any suggestions about this.
So I think we've seen more of this surge of referrals for treatment before surgery for breast cancer, for example. There's been a huge surge in the number of people who are starting drug treatments to tie them over until when the operating up. We have to be cautious about operating rooms because and even the diagnostic procedures for lung cancer, biopsies with needles going into the lung, bronchoscopies where the camera is going down through the airways, or operations where there's an intubation happening. All of those we call aerosolizing procedures. So all of those things do put the healthcare workers at risk as well. Now that doesn't mean they're not happening. They are happening a little bit slower because of all the extra PPE and precautions that need to be happen. So there is a bit of a slowdown. Actually, in Ottawa, we've seen a slight slowdown in lung cancer surgery, but not devastatingly so, and not to the point that we've been asked to give treatments pre-surgery. I think we would be open to. There's certainly good data for chemotherapy before surgery, less information on immunotherapy. But I think we would be open to doing that. And if somebody had one of these molecular targets, well, it's not standard. I don't think I'd have any problem using those tablet medications to get people through to an operation.
Jump to systemic therapies, especially immunotherapy, chemo, and target therapies. Do you think you addressed this as not being the same risk of complications for COVID? And one of the myths that were said throughout the start of the pandemic is if your patient is under immunotherapy, you're not really at high risk because their immune system is kind of not low. So does this actually, and that's why they pushed a little bit to approve, for example, pembrolizumab for everyone above 1%, although the data was not really convincing before, and the combination therapy with the high risk of toxicity and everything else. So how did you address this in practice in the choice of therapies, outside targeted therapies?
Yeah, so I think what's kind of reassuring is that in general, we haven't made many different recommendations at all in terms of the core essence of somebody's treatment. So if you need immunotherapy, you get immunotherapy. If you need chemotherapy, you get chemotherapy. If you need the combination, we've been giving the combination. I was in discussion recently with Professor James Spicer from Guy's and St Thomas's Hospital in London, where London was a big hotspot for coronavirus, and they were still able to deliver a lot of their treatments to even under quite difficult circumstances. So the changes in systemic therapy that mostly we've seen have been, I think, quite safe. So, if I see someone in my clinic a year ago before coronavirus and they had influenza, they had the flu, or they had a bad cold, or they had a urine infection, or they had gastroenteritis, we routinely say, well, look, you better just recover from that, and then we'll restart your chemotherapy or your immunotherapy when you're recovered. And I don't think any of us have any worry about doing that, and that's the right thing to do, and does not result in harm to our lung cancer patients. Mm-hmm. So we know, and also, it's quite common that people come in for their treatment. We do a blood test. Blood test isn't quite right, so we maybe delay the treatment a week. So delays and pauses in treatment are something that has been going on for a long time. So I think we maybe got slightly over anxious about this, about delays in treatment during the pandemic. And so, if people have missed a treatment or a couple of treatments and then are getting back on their treatments, in the last few weeks. And in fact, there's a comment in the chat box for someone who's had that happen to them. And I obviously I don't know your exact case, but in general, the principle of that is it's fine. And then further, and to your point, we've been able to change some of the regimens, which we've been wanting to do anyway before COVID. We've been advocating for some treatments to be given every 4 weeks instead of every 2 weeks, or every 6 weeks instead of every 3 weeks. We've been pushing for that anyway, but our regulatory bodies were moving at the pace that regulatory bodies normally move at. Mm-hmm. And suddenly the coronavirus comes along and everybody gets a wiggle on, and we can get these things in much more quickly. So now there's a lot of people who don't need to come to hospital as frequently. They've maybe had a break, which I'm sure in almost all cases is probably perfectly mm-hmm. safe.
Yeah. So yeah, exactly. This is, and also just follow up for Janice's case. I'm sure it depends also at what time the postponing the treatment was done. It was done after the first injection, or it was done after a year of a controlled disease. So this was also to be taken in if there's any way complete response, if there's a partial response, if there's stable disease. So every postponing a treatment is always personalized based on how is the result and how is the tolerance and how. But in general, it's not much of a big deal if the oncologist took this decision, because most of the time, we especially with immunotherapy, the dosing and the schedules were done, and now we're seeing the change. And this was actually, just to talk about this, like the COVID, it had a lot of negative issues on everyone, but one of the positive things is that it accelerated some things that technically we've been advocating for them for a while. And then people said that, oh, now we're in an emergency situations and let's change them. And one of the things that we realized is also how pertinent and how important was to do that many CT scans for our patients and do lab works. And I'm sure you've done less scan that you've ever done in your life, and your patients are still doing fine.
Yeah, I think in general that's very fair, and certainly it's an individual issue for each patient. And as you say, it's this kind of devil in the deep blue sea issue. Like ideally, you do keep on your treatments on schedule. We generally don't have too much of a worry if you need a break, but I wouldn't want you to have a break if you've just started and you've got a lot of symptoms and we're in that initial trying to get things under control. On the flip side, though, I think you're right. And a lot of the things that we've learned and we've implemented are positive, that we've wanted to do. And now, given this, we've taken this as an opportunity. On the flip side, though, maybe some things that we've changed to do that we recognize are not ideal, and we need to go back. So, and I think the biggest example of that, at least in my practice, is we've gone to, virtual visits for the vast majority of people. So, we use Zoom, telephone, various telehealth hubs to meet with our patients. But it is not ideal, and it's difficult to do a proper clinical assessment without sitting down with someone face to face. And so, I'm looking at Anne Marie here, and I can get a sense that Anne Marie looks quite healthy. But there are other people where, when you're speaking on the phone, I'll give you an example. I met a guy for the first time about 10 days ago on the telephone. He's in his 60s. He just had a lung cancer operation. He's stage 2. Looks like he's going to be cured. And I was asked to see him to discuss chemotherapy. And we did it by telephone. And he didn't sound too hot on the phone. He had a gravelly voice. It was stuttering, was difficult. And I was thinking, I'm really not sure that this man is fit enough to go through a course of chemotherapy. But it was on the phone. So I said, well, look, why don't we meet in person in a few days? And so we met up in person, and he just had a deep voice. He was really strong, healthy guy, keen to go ahead with his treatment, and I had no problems doing that. So we have got to learn that, some things that we've changed to are not perfect, and
yeah, I totally agree with that. I mean, telemedicine did solve a lot of things, but honestly, especially for cancer care, for treatments that, especially for follow-ups of and evaluation and clinic, I mean, it's not going to be feasible to continue, especially the first contact with your patients. There's a confidence, there's a trust that you need to build at first. And that's why this is something you can't do over the phone. I mean, after a couple of years, Anne-Marie's going to tell us about her experience, but I mean, after a couple of years on a certain drug, if your blood test is stable, your CT scan is stable, yes, you can follow up with that over the phone, but at the same time, you're going to still need wanting to come see your physician. One of the things that I just want to address to Heather in the comment, the problem with delaying CT scans or delaying treatments is always based with the discussion with your oncologist. Because one of the reasons is sometimes we don't, delaying a CT scan will not change the response to therapy, is going to make us change the evaluation of your situation as well. And that's why one of the things that would be very, very important is when we delay a certain treatment, we need to weigh the benefit and the risk and the situation, and we're going to address that at a later term. One of the other things I wanted to mention before we end this part is how were you following with the side effects and the compliance of patients over the phone, but mostly side effects of immunotherapy and side effects that need usually management with the clinical physical exam?
Well, so what I'm doing is, I think probably what most of us are doing is we start with a telephone visit, and the vast majority of people who at the other end of the phone line to me are perfectly smart, sensible, reliable people who can report their symptoms. And so we have a discussion, and then if there's a concern, then I arrange for an in-person visit. And I try and coincide that with when they're coming to the hospital anyway. So if they're coming for another clinic appointment, or they're coming in for a blood test or something, we try and combine visits. But if there's any doubt, I'm seeing people in person. Maybe I'll just add to what you said to Heather, because I think we hear this time and time again, that there's a lot of the waiting is stressful. And maybe Anne Marie can touch on this in a bit as well, but waiting for a diagnosis, waiting for a treatment, waiting for a scan, waiting for the result of a scan. These are very these are very stressful times. And so I think it is a responsibility that as the oncologists and the medical profession, we have to take on, that if there are going to be delays that really are safe, that we can effectively communicate that to you, to say, look, I appreciate that this can cause anxiety, but look, I've got your back, and this is okay. And so that, that's on us to try and be as reassuring as we can. And if we can't reassure you because we don't think there should be a delay and that we're worried, then it's also on us to then advocate within our healthcare system to make sure that you are prioritized to get those treatments or tests. And the other thing is, when you do come to hospital, hospitals are pretty safe places right now because they're empty. Yeah? There's no visitors, everybody's wearing a mask, everything's wiped down 100 times a day. So actually, while we say we want to keep you out of the healthcare system, it's not such a dangerous place to be. It's probably safer to come to the cancer center than it is to go to the grocery store.
Yeah, for sure. Yeah. Last question, treatments for clinical trials. So I believe lots of clinical trials were held during the recruitment times. And one of the major stress, I have many patients that are actually going through therapies through clinical trials, and that had everything changed. I mean, how valid would still the results be with all these changes? Was there any amendments for the follow-ups? Did any trials close beforehand? Did any trials didn't open? And how would you see the future of creating new trials coming up?
Yeah, so this I think has been a challenge. And in Ottawa, we're a big academic center. We have a big portfolio of trials across different cancer types. And so every center's probably done it differently, but I can tell you for us, for people who were already on a study, that was fine. They stay on the study. You can't ethically take somebody off a treatment. And so we kept those studies going for people who were already on the study. And there were some adaptations allowed. For those of you who are listening, who have been on clinical trials, you'll know that they're very picky, and there's very specific days that you have to attend, and scans at this point, and blood tests just so. And so we were given some flexibility in that. We were given some flexibility in doing virtual visits, etc. The problem was we were not allowed to enroll new people onto studies. And the reason for that is because of those picky nature of clinical trials, there's more visits to hospital, there's a bigger impact on the healthcare system. There's more people involved in your care from the clinical trials office, be it scans or additional biopsies or blood tests or EKGs for your heart. There's a lot more going on. And so to reduce the sort of footprint of somebody being on a trial, the enrollment was closed to most trials. And now we're starting to open them. And there's a process of prioritizing which trials can be opened first. And it's generally the ones that offer the biggest impact for the patients, and the ones that at the moment have a smaller amount of workforce implications. But we'll get back to that. But that has been a challenge.
All right. My last question for you is, how do you think we compare to you? I've seen you on many webinars and conferences with different people internationally and nationally. How do you think we compare to what happened? What would be the thing that if you go back, you would have done it differently in Canada compared to other countries, and compared to what we did as reaction?
Oh, you know what, Ellie? If you will forgive me, I'm going to duck that question and say, why don't you ask me again in 12 months? And the reason I say that is there's a lot of work going on now in Canada and internationally to really try and understand the lessons of what's happened in the last few months, and we can apply those to a future wave, whether it comes in the fall or in next winter, or indeed maybe another pandemic, whether we have a SARS or a MERS or something else coming. And so I think that, I mentioned some of the stuff that's come from the UK. Specifically for lung cancer, there's an initiative called TerraVault, which is an international collaboration to try and understand the impact of COVID on lung cancer patients who contract coronavirus. Within Canada, we had already started an initiative called PALIOS, which is the Pan-Canadian Lung Cancer Observational Study, which is multiple centers in Canada that are starting to contribute a lot of information about lung cancer in general, and we're hoping that that will expand to other centers. Quebec City is likely to be the first one from Quebec, Halifax, Ottawa, Brampton, London, Toronto. There's a number of sites. And what we've been able to do is get some additional funding to build a COVID module onto that to specifically collect more information so we can understand the impacts. So I'm not sure I could say we would have done anything differently. I think we reacted quite quickly, quite thoughtfully, cautiously. But the real learnings, I think, are still to come.
Okay, thank you so much. We're gonna move to Anne Marie. Very happy to have you. I'm just gonna unmute, and we're gonna get back after that to the last questions that were asked in the chat.
Sorry. Hi, everyone. I'm going to apologize ahead of time in case my dogs bark because they are both lying here next to me. It's interesting because Paul was saying that different patients will experience different things. And I think because I've been around for so long, I've experienced them all. So I've had chemo, radiation, and surgery, and now I'm on a targeted therapy, and I've been in clinical trials. So I kind of run the gamut. And I'm currently in a clinical trial right now. So, so yeah, please, let's go away.
So our quick questions, did you feel, what did you feel changed mostly when the COVID happened?
I think the biggest thing for me that changed was the televisits. I actually had my last clinic visit was on the first day that everything kind of closed down, so it was a little bit weird. And then after that, we all started going to the telehealth. So I've had a few follow-ups through the telehealth, and it's mainly been on the phone. But I think, yeah, I definitely prefer in-person visits, or at least on-camera visits. It's a little bit more personal. The other thing was that I had to just go to a different location to get blood work done. My medications were couriered to me. So things didn't really fall apart. It was pretty seamless, actually, all things considered. I had my first scans during the pandemic like 2 days ago, so I did actually have to go to the hospital for that. But it was pretty deserted, and it was very quiet and clean, and they screened me, and I had a mask, and everyone had a mask, and I kind of, didn't touch anything, and I went on my merry way. So to be honest with you, not a whole lot really changed for me. I think the biggest change was kind of learning how to navigate it kind of within my own sphere of stress and anxiety and all that. That was the biggest thing for me to kind of overcome. Everything else was pretty much handled very well and very professionally.
How can you comment on the communication with the healthcare workers? So what did you feel worked? What did not work? What would be a good thing to do? And what was good that happened, and what was really not a good idea?
So my nurse is really great, and she contacts me for pretty much any changes or anything like that. University Health Network.
Calls, or was she the ones initiating the calls, or you initiated the call?
So actually both, because if I had a question or any concerns or anything like that, I could call her, and she usually got back within the day. And if there were any changes kind of on their end, she would inform me. The other thing that's really good is that, and I know this isn't available everywhere, but I know the University Health Network has the My UHN portal. And so you can log in there and you can see all your appointments, all your scans, all your everything. So that's another communication tool that really didn't change much. I think I think what I would have changed is my oncology visit was done over the phone. And I think for that, I definitely would have preferred having it sort of, even if it wasn't my oncologist and one of the team of fellows, would have preferred having it sort of via Zoom versus just a telephone call. I think that was maybe a little awkward. But besides that, really, I think communication was quite good. I also had a few emails that were sent to me. I guess with one of my psychosocial appointments, there was a little bit of confusion, but that was resolved. And it was just that they had the wrong email was written down. But, that's sort of technical errors, I guess. But really, I think
the hospital had your email address as well to communicate with you.
Yeah.
Okay, that's a good idea.
Yeah.
So another question: what activities did you adopt actually with the current situation, just to reduce first the anxiety, the stress, and at first, and then the second part is to prevent yourself from being infected, because I believe you had a lot of worry. You were so worried to get COVID. Right?
I think to keep myself calm, I just made myself really busy. I took up a few different hobbies, new things to do, learning how to play a different instrument, paint, basically anything I could occupy myself with so I didn't have to think. I tried to limit the news to like one time a day. And essentially it was just, I think I had a little storage of masks that I had from beforehand. And so whenever we absolutely had to go out, they were used. And, hand washing was essential. And besides that, we didn't go out unless we had to. We try not to touch our face and we wash our hands. And I think we were a little bit more adamant about it in the beginning. But I think we've sort of eased into a bit of a routine where at least my husband and I are quite comfortable. I was happy when they said that for people to wear like non-medical masks. I thought that was good because I kept thinking, well, if I keep my germs and you keep your germs, then no one's getting sick. So I was a big proponent of the mask. But really, besides that, it was a lot of things I had already done before going through chemotherapy and having compromised immune system. It was just going back to that kind of a life. And so I think in that way, cancer sort of prepared me for the pandemic. Whereas, it might have been a big shift for people in general.
Did you have to go to the hospital during before your CT scan, like to do any lab tests? Did you have any?
So I didn't have to go to the hospital. What they did was they arranged a blood draw at one of the local, blood labs that's affiliated with the hospital. And so it was close to my home. I went there and got my blood work done. And that was really the only other interaction that I had with sort of a physician, medical nurse. And then just basically the pharmacist at the drugstore. And those were really my only interactions with sort of the outside world.
Okay. And one thing, like for sure, you've been diagnosed a couple of years ago. And your confidence with your healthcare team and oncology team has been already in place for the last couple of years. So what would you steps or what recommendations would you give to healthcare professionals to be able to gain this confidence in times like these when we get diagnosed with when we have new patients? What worries a patient at first diagnosis?
Oh boy, that's going back a long time. I think to establish trust with patients is you're open, you're honest, you're willing to listen to them. Certainly, I think the big error that happened along my sort of path was that, when I experienced recurrence, I was kind of like there wasn't a lot of exploration done in terms of what could be done. And we're talking like 10 years ago. So I think those kinds of things really help establish sort of a foundation of trust. I know that anytime I ask a question, it will be answered. And I know anytime I have a concern, it will be addressed. and I feel like that I'm heard. And I feel like that is a really big thing that will establish a good rapport. I've been very, very fortunate to have wonderful, wonderful physicians. And I've been very, very fortunate to have a lasting response where I got to actually really know my physicians for, 3 years, 5 years, etc. So I really do trust my team.
Perfect. Thank you. So I'm gonna leave after that the questions to Paul. One last question. So
Can I ask Anne Marie a question?
yes,
Sure.
Anne Marie, were you offered a COVID test?
No, I wasn't. I think if I had had symptoms that I would have been, because I know that they were saying they were testing everybody at Princess Margaret, or that like if you were screening negative that they would test you. But I didn't experience any of the symptoms, so they passed me. So I didn't have a test, but I imagine that they would have definitely said yes.
I think everybody's going to be tested, certainly if they've got symptoms. But I'd be interested to hear, maybe, Ali, what's happening in Montreal, because certainly in Toronto at PMH and in Ottawa, we're now testing everybody who's about to start a course of chemotherapy or immunotherapy.
Yeah, exactly.
We haven't quite moved that to the oral treatments. But
that said, I haven't been back to PMH yet. I'm going next week. So email me next week and I'll let you know.
Yeah, we had this recommendation just changed a couple of days ago, and this would be, I don't, applicability of this would be very challenging in real life, because we have lots of patients that go between different hospitals to get their CT scans, their PET, their biopsy, their follow-up, seeing radiation oncologists. So with every journey, there's a risk of infection. So at what point would you infect them? The night before your surgery? There's a lot of side effects. If you get the serology test and your patient is already immune, would you test them again? What are the guidelines for the testing are still, they're logical, they're reasonable. Yes, we should test everyone to whom we will give chemotherapy and reduce their immune system. But I believe the applicability of these testing would be very challenging, especially with the schedules that we give. For example, Pembro every 6 weeks. Who knows what happens during these 6 weeks, and especially that we're still giving patients their treatment in rooms where they are in contact with different healthcare professionals. And if we want to increase the number of patients that we are able to treat, maybe we should re-evaluate how many patients we treat every day, and because now there's distancing even inside the room with where we give treatments. I had one question for Paul. Are you vaccinating your patients for pneumonia, pneumovax, and other than the flu vaccine?
You know what? That question has not come up yet in our cancer center. So people are still getting, well, we're kind of now coming out of that season, aren't we? So that natural season for normal vaccinations, for flu and for the pneumovax and Shingrix, and kind of out of that season. So, that's just not come up. I don't know. I think we'll probably stick with our normal advice on that.
Yeah. I'm just gonna have last comment for Marla. So happy things are going good. There's one thing that she highlighted, actually, the change in some protocols for the adjuvant therapy, which we used as well. I mean, some hospitals, like we have data with pemetrexed as platinum as for adjuvant, but yes, some hospitals changed their protocol to decrease the risk for first, it's a regimen that would make you come just 4 times to the hospital compared to coming, like 16 times if you're going to give vinorelbine cisplatin in the adjuvant. I don't know in your practice, were you giving as adjuvant, but we switched as well.
So it's been I think it's been physician dependent. I personally did exactly what you've done and have switched to platinum pemetrexed. So like you say, it's just 4 treatments once every 3 weeks. The regimen that I was using involved 8 treatments. So halving the trip, a little fewer side effects. And yeah, with no concerns, I don't think about safety or effectiveness. So these are some of the things that, we've been able to change, which has been nice and has been beneficial for patients to be able to make these changes. What we are going to wait to see is, when this wave is through and we come back to something approaching normality or the new normal, are our regulators going to go back and say, okay, you've got to do it the old way again now? Or will they allow us to keep some of these advantages that we've adopted? And I think the other thing, if I can put on my Lung Cancer Canada hat on for a moment, and from an advocacy point of view, is I think what this has also highlighted is some of the discrepancies in access to care that we have been highlighting for a long time, but have become much more stark given the pandemic. And the clearest example of that, at least in Ontario and many provinces on the eastern side of the country, is that oral cancer drugs are not funded the same way as intravenous cancer drugs. And so it can sometimes be much harder to access an oral cancer drug. And this is, of course, exactly the time when we want our lung cancer patients to be, well, first of all, getting the best treatment available, but in many cases that is an oral treatment, and we haven't been able to easily get to it because of really some silly, unfathomable reasons that our regulatory system is like that. And so there's one guy that I've had to give 3 days in a row of intravenous chemotherapy because he couldn't afford the oral version of the drug, and we couldn't get it in time for him. And so what I'm hoping is that we'll be able to take some of the good things that we've changed and keep them, and some of the bad things that we've been wanting to change, this will give us the impetus to really advocate for that. And so when we come out of this, there will be a lot of elements in lung cancer care in Canada that will be stronger. On the flip side, there are other things that are going to be harder. We felt we were just starting to build momentum to implement lung cancer screening in Canada, which is that early screening with CT scans to detect cancer before it becomes symptomatic, and it's much more common to be then stage 1 or 2. Well, most screening programs have just come to a grinding halt, and so we've got to push for that. And then as we recover from this wave, we're going to have to be very nimble as a healthcare community to not just be ready for a potential next wave of coronavirus, but before that, we've got a wave of people who, like you said, Ellie, have got lung cancer, but they don't know it yet. And so we're now going to get a wave of people who are now starting to get engaged with their family doctors again and starting to get referred because of symptoms. So there's a lot of waves that we're going to have to deal with. So we're going to have to be quite flexible and nimble, but I'm an optimist in life, so I think we'll get through that, and then we can find some opportunities.
Amazing. Anne Marie, do you have any question for us?
Not really. I read something actually the other day that it was a vascular disease versus a strictly respiratory disease, and I thought that was really interesting, and I wondered if you had anything to weigh in on that.
You're talking about COVID, right?
Yeah. Like I read that it was a.
There's a lot of questions about how is COVID causing, how is the coronavirus causing the COVID. One of the things that we know is two things: that the cytokine storm and the thromboembolic disease. This is how patients are really getting all the complications, and this is how the patients are dying. Now, how is this happening? What comes first? Is it the respiratory problem, or is it a vascular problem, or is it an affinity to the hemoglobin? We still don't know. And one of the major things is that there's one which is the symptom of the other. Because if this is a problem with the small vascular system, that the vascular system of the lung is causing the problem, or is it the problem of the lungs and the problem of oxygenation which is causing the problem of the vascular disease? We still don't know. It's close to the egg and the chicken for now. And yes, there are a lot of theories. We wrote a lot about this on the website. And if you want to go and check that on howitreatcovid19.com, we talked a lot about the vascular versus the lung. It's still not solid data. I'm sure, and I'm hopeful we would be able to develop a vaccine before we even find which one comes first. But yes, this is the major problem. Is it the lungs or the vascular disease at first? But the more main problem is a cytokine storm and a thromboembolic disease that cause all the death.
Thank you.
So thanks again, Paul. Thank you, Anne Marie. Thanks, Boaz. Thanks, Lung Cancer Canada, Association Pulmonaire du Québec, and the Coalition for all the help in organizing this. If any one of the attendees have any other question, please reach out to us on by email, webinars@howitreatcovid19.com. And we hope to see you everyone live somewhere sometime soon. Take care of yourselves and have a nice summer. It's going to be good this year, I hope.
Thank you.
Bye, everyone. Bye-bye.